And maybe that fits in well to this session today. The Swedish government realized the problems that you also confront in the US and all over the world. So in the Swedish Research Bill in 2008, they said we want Sweden to do good research in a number of areas. And you've seen marked care science, and with that they mean all kind of research that is clinical, patient-centered, so to speak, and involves clinical medicine, economy, and all disciplines. And the vice chancellors at all the universities were asked to come in with proposals to get some money to do this research, but only 1 or 2 universities would be able to get the money. The Swedish government said that we need research in organizational care and how to practice good care, health technology, and the significance of care for society and industry. Please show us if you have this kind of research. And the Vice Chancellor asked me to take the lead in this proposal, so I invited all deans at the University of Gothenburg, and we have about 45,000 students, and as you see, a number of faculties, and we had an open meeting. I just wanted us to make a consensus. What can we offer in these areas in relation to clinical research? And as you see, all the faculties at the universities decided to be involved, the top researchers, I should say. And we decided we must focus on person-centered care at that point. And this is a way of trying to illustrate how we organized this big group that is now consisting of 100 researchers, and we were also given this grant on 30 million euro and started up the Center of Person-Centered Research 2010. As you see, we focus on person-centered care, basic research, long-term research, applied research, and also implementation. And we have core concepts. The core concept in this is partnership. You need to work from seeing the patient as a partner, as a person. We start with the narrative, we formulate the partnership, and we document this. And I will show in a very practical way how we do it. And of course, research, education, and utilization is what we concentrate on. Here you can go into our website and read more about the different research groups. And I will give you a few examples of what we have been doing since 2010 when we started up. It is person-centered care and long-term illness. And this is how we think when it is about disease. We differ between disease and illness. Disease is the objective manifestations of sickness or disease, while illness is what you experience and feel, often described as symptoms. So we have research groups in heart failure, patients with heart failure, and as you can see, do I have the pointer? Yeah. In heart failure, we can manifest the manifestations of objective disease in terms of reduced ejection fraction and biomarkers and so on. But you can feel well. You can have these objective markers, but you can feel well. But you can also have a lot of symptoms in heart failure and have this objective disease. We have cirrhosis, diabetes, hypertension. In all these fields are researchers exploring and evaluating person-centered care in patients with these kind of conditions. Here they have severe symptoms and these kind of disorders. We have no research if you feel absolutely well. We do not see the point in that. But you can have a lot of symptoms but no objective disease. So when we do this in practice and evaluate it, we initiate the partnership by the patient narrative. And someone told me during the coffee break that it is difficult sometimes to narrate something, and the health professional need to be very skilled to take that narrative and identify the possibilities to make a personal health plan. We work the partnership, we share decision making, and we show concrete how we do it, and we also document this in the patient record. First of all, the patient narrative, how do we do it? You can't read anything of this. It's just a way of illustrating that the free narration from the patient is documented in terms, often in figures, numbers, and of course evidence-based medicine is involved in this. It's very much like what was presented yesterday in the person-centered care plan that Juan and several others presented. Evidence-based medicine and narratives are integrated in the document. And we have some very simple questionnaires with a few items. So from the narrative is written down. From the narrative, we go into the next step in working the partnership, which is the shared decision making. Normally, hospital care is like this. This is the case of being hospitalized for heart failure, worsening heart failure. The physician establishes a diagnosis and prescribes treatment first 24 hours. And then the nurse or other health professionals, I exemplify with nurse, carry out the prescriptions and care for patient and start planning for discharge. The patient is absolutely passive, answer questions, but have no other role in this field in the hospital. And this is what we do. The patient is the most important person here and is allowed to narrate, to tell about his or her condition. How is daily life at home? What are the symptoms? And we try to identify resources that we can build on in the plan. And already the first hours, 24 hours, we discuss discharge. And this is also the different responsibilities of the physician. Of course, the diagnosis, prescribed treatment and tests, but discharge and goal for the days to stay in hospital are discussed. And the nurse often take the narrative and put down the information that is needed. The nurse or dietitian or some health professional can also be the physician, of course, and discharge days. So it's a team. And finally, we have to safeguard the partnership. And before coffee break, it was some discussion about how to document this, and it was also talked about the nurses write papers all days and do not have time to care for patients. We do not see this as a huge work. It can be made very simple, and we save a lot of time by working this way. I will show you how. But this is a way of creating the partnership. We write a contract. This is in Swedish, but here the patient sign, here the physician sign, and here the nurse sign. And what is written here is an agreement on how many days do we think this hospitalization will take, and are we in agreement to plan for that and to work for that. It was not easy to introduce such a contract, I can say. The patients love it, health professionals don't. And this is how a plan can look like. And I know that some of you recognize and work in a similar way. The patient's goal with his or her illness or disease are discussed. What would you like to attend? Often in this case, this is about acute coronary syndromes. Going back to work, when will this be possible? What activities are needed to reach this goal? And what are the capacities of the patient? Yesterday I had a short talk about how important it is to identify capacities in the patient, and the skilled health professional need to be able to do that. And what support is needed, what do the patient need from us. But this is the patient's own document, and he or she take responsibility for that. Here an example of health diary. The patient can write down and follow his or her own symptom development. It's not something that is sent into the hospital or primary care center, but this will be presented more in detail later today. And the results of this way of working is presented in this article in European Heart Journal, and well, positive result. We shortened the hospital stay by 30%, activities in daily life was better preserved, and the feeling of uncertainty in illness that is quite common in patients with chronic heart failure. They improved and they felt more sure about the treatment and care. As you see, it's more concentrated the days they stay in hospital. Also, municipality care and primary care are involved in this way of planning care and treatment. I understand that my time is over now. Is it?
5 minutes.
Oh, I thought you were announcing stop. All right. As you saw, it was a positive results, but the government do not only want us to do research and get them published in good papers. They say you need to take responsibility also for the results. You need to implement them, and you need to be there. You cannot be in your offices or laboratories or whatever. You must be out in society. You must work with implementation. So, of course, we are asked to perform excellent research. We need to take the lead in that and therefore publish in good papers, but also educate and train health professionals, also patients, people, society, and utilization and also research and utilization, which you will hear more of later today. We try to discuss with other stakeholders on an international level, but national of course, and we have a yearly summit with high-level people, and from this community, Juan Message attended this year. Otherwise, we had from politics, academia, a roundtable, specially invited people, about 35, where we discussed, in this case, it was how to implement person-centered care, because this is really a challenge. And we've also started up wards at the hospital. There we strictly follow the care day to day, that it is person-centered in every detail on a practical level, and also at discharge and out in the primary care centers. But as you can see, this is the ward, internal medicine ward. We have clinical research, a lot of researchers involved in that very, very clinical patient-centered, but also research on the staff, as you can hear later more today. Of course, IT implementation and research, service innovation. We have talked a lot on how to do it, how can we do person-centered care. We cannot just say we need more staff, we need more because we grow older. We need to do care in a totally different way. And as you can see, by doing person-centered care, we save hospital days, we save money by making patients more responsible, taking more responsibility for their own health. So it's a way of reducing our own control. We love to keep control of our patients. So we educate, as I said, all levels of society. And last week we got information that we were given the EU grant, where we have, where we will work with during 2 years about the future healthcare with key players in Europe. From, as you can see, Sweden, of course, we are the coordinators, but UK, you know, they have a strong movement on patient involvement, both in research and, of course, in practice. And we also have Germany, the Netherlands, and so on. And these are key players from politics, academia, and also industry. For example, IBM and IMEC are involved in this work. So we will meet in a few days and start up with this important work. So in summary, GPCC, Gothenburg University Center for Person-Centered Care, but we shorten it, GPCC, is around 100 researchers that are involved in person-centered care research from all kinds of disciplines. Results from research has proven that person-centered care improves well-being and reduces costs. We integrate research, education and innovation and put knowledge about person-centered care into practice in conjoined activities. Thank you.